and welcome to this lecture. And please excuse me about the background, whatever you see behind me. I'm using my daughter's room, so there are various images that you may see. Just ignore them. I'm just using her room because I'm doing the lecture from home. Just to minimize the disturbances, I have selected her room as the least disturbance room. Okay, so we have met before. I'm Hasni Bannahaka. Well, I think during the introductory lecture, we met each other. So I'll get started straight away. I have anyway given you I have uploaded the lecture to LMS, so you would have downloaded that, some of you. And even those who miss, they later on can actually listen to the recorded lecture, as well as you can get the updated version of this lecture topic, lecture slides later. Okay, so with the case history. Okay, so this is a case history from CDC site. I have given the reference. A 29-year-old female patient presented to her primary care physician, that is a general practitioner or the family doctor, reporting a 15-day history of whitish vaginal discharge associated with itching. She also complained of lower abdominal pain. A vaginal speculum examination revealed an inflamed cervix with red punctate lesions. A pap smear collected at the time of examination was sent to the pathology lab for a papanicular stain. Figures A and B shows what the pathologist observed using an oil immersion objective. The objects of interest measure 10 to 15 micrometer long, and they're asking what is your diagnosis and based on what criteria. Okay, so this is a typical case history of a patient with trichomoniasis. And the organism, if I show you, let me take the laser point. Okay, so this is the organism that we are talking about. Again, here you can see the organism. So this is the parasite which causes this presentation. And these are, of course, epithelial cells. You can just ignore them for the moment. So with this case history, you can sort of realize what kind of a disease is this. So with that, we'll move on to the lecture per se. Okay, so starting off with the objectives. First, we'll see the parasite that the case history that I presented is caused by a parasite called Trichomonas vaginalis. And so I will be talking about the identification features, the morphological features of the parasite, and then we'll see the mode of transmission, how it is transmitted from one human to another. And then we'll look at the pathogenicity caused by the parasite in the human. And then we'll look at the clinical features of the disease Trichomoniasis. And then we will look at laboratory diagnosis, treatment, prevention, and control. Okay, so those are the learning objectives. With that, this is just a slide to give you an outline as to what kind of things to expect. This is just the outline of the lecture, so I'll skip that slide and we'll get on to the importance of trichomoniasis. Okay. So trichomoniasis is a sexually transmitted infection. Now you have learned a lot of other parasitic diseases by now, and the mode of transmission was mostly fecal-oral or other modes where you have not learned anything which are sexually transmitted so far, except for if you have learned giardiasis, there's a possibility of people who are involved in sexual activities getting giardiasis, but it's not a sexually transmitted disease either. So this is the first sexually transmitted infection in parasitology that you are learning. Okay, so this is relatively common. What do I mean by relatively common? Now you have again learned various other parasitic infections by now. Most of those are actually rare or very uncommon or not. You will not see them during your encounter in the hospital. You will not encounter them in the hospital clinical training that you will undergo. So this is relatively common, means this is something that you may come across in the sexually transmitted infection clinics. Okay, so this is not so uncommon or rare comparative to the other parasitic infections, mind you. Okay, so relatively common does not mean like cough and cold or upper respiratory tract infections. I'm just related to the other parasitic infections. Okay, and then this also, now one feature of parasitic the sexually transmitted infections is that they coexist with other sexually transmitted infections. Now, by now, I don't know whether for microbiology you have learned other sexually transmitted infections. If you have, or when you learn them, you will understand that if there is a patient who has one sexually transmitted infection, there is a possibility that that person has another parasitic, another sexually transmitted infection at the same time because of the similar mode of transmission. Okay, so the other thing that you need to know is the clinical presentation of trichomoniasis is, it's not characteristic to trichomoniasis per se. There are others who sort of have the similar presentation. Now, I just started, when I showed you initially the case history, you would have realized that that case history has particular various presentation, clinical presentation and the clinical features, and then certain other associated symptoms. Those are not only for trichomoniasis, there are other diseases which can have similar presentations. So we will learn as we go on. And there is a rare possibility of getting certain complications which are associated with trichomoniasis, which the researchers have proven to have to do with something to do with trichomoniasis, they say, but those are very rare things, and I think you can just ignore that statement. Don't have to be bothered much, just for your interest's sake, and for those who are going for distinctions and first classes and uppers. Well, the possible outcomes are sort of they can make, if it is in a pregnant woman, that person can have low birth weight, delivery, or various other female genital tract related infections which you have not learned so far. So don't want to tell you all those, but that's a very rare thing, so we can just skip it. Okay, right. And then I'm just going to give you some input into global prevalence. Again, these things you don't have to remember, you don't have to know what the prevalence of any disease, because you can always check a book or check a website and see what the prevalence is. I mean, you're not expected to remember those figures and statistics. This is just for you to understand the intensity of, not the intensity, the burden of the disease in the world. Okay, so usually this disease burden, the exact actual data, the world does not have, because this is not a reportable or notifiable disease like some other diseases. So these patients, because of the stigma attached to the disease, they may not go to the sexually transmitted infection clinic. Instead, they will go to the general practitioner or the known family doctor or somebody and get it treated. So they don't come into the data when they get the treatment like that. Okay, so global prevalence depends on the risk level, and what WHO has estimated. This is an estimated thing. This is not real data. They estimate that there may be about 156 million cases in the world. Okay, moving into the Sri Lankan situation, Sri Lankan prevalence. Now I said it's comparatively common disease, but comparative in the sense I told you, it's comparative to the other parasitic infections. But if you take the STIs, now STD stands for sexually transmitted disease. If you take the range of sexually transmitted disease that are prevalent in Sri Lanka, this one is kind of at the bottom of the list. Okay, so you can see the other common ones in blue print, which you may have learned by now for microbiology, or you may not have. But when you learn, I mean, trichomoniasis is in the bottom of the list, basically. Okay, so the prevalence, again, I mean, these data have come from research done in medical faculties mostly, and these actually we have done in these clinic-based populations. So you cannot extrapolate those data to the globe. general population, because these are in a specific selected sample. So anyway, WHO has also taken the Sri Lankan prevalence from a study that I have done. So they say the prevalence in Sri Lanka is 2.8. So that's usually the rough prevalence in Sri Lanka. Right. Okay. So now we are moving on to the important part of the lecture. That is, we are going to learn trichomoniasis per se. Okay. So when you take humans, there are different parasites. There are different trichomonads. If you take the trichomonads type of parasites, that also there are 3 of them. Now, out of the 3, you're not going to learn the other 2, which are commensals. You are going to only learn this pathogenic one, which is the Trichomonas vaginalis in the genitourinary tract. Okay. So the other 2 are commensals. So I'm not going to bombard with all the information regarding these 2 Pentotrichomonas hominis and which is in the large intestine, and the T-nex, Trichomonas T-nex, which is in the oral cavity. We can just skip those 2 because we are not only going to learn the pathogenic ones. Okay, right. So before I speak about Trichomonas vaginalis, the parasite today, just wanted to remind you or refresh your memory what you have learned so far and what I have mentioned in the introductory lecture. Now, during the introductory lecture, I told you that we have protozoans. We will start teaching parasitology with protozoans, and these protozoans we categorize according to the way they move or based on the appendages that they have. So in that, if you remember, I told you that there are flagellates. Okay, so as you could see in the picture itself, now today we are going to talk about a flagellate which is called Trichomonas vaginalis. Okay, so the flagella is used for mobilization or the movement of the parasite. And also during the introductory lecture, as well as during the previous lectures, you would have learned when you talk about is amoeba, or when you talk about giardia, or even crypto, you talk about when you talk about giardia and amoeba, you would have learned that the life cycle has 2 main 2 stages, cyst and trophozite. Okay, so lucky for you, this has only 1 stage, that's trophozite. So the life cycle is quite simple and it's not complicated. I am not even going to show you the life cycle because now the life cycle stage is important for us to know what the infective stage is, what we get it when the mode of transmission happens. So that is trophozite. And then we need to know what the stage of the life cycle that was pathogenicity. So since this does not have 2 stages, it is again the trophozite which causes the pathogenicity. As well as now we also want to know what the diagnostic stage. So again, this doesn't have cystic stage, so it is the trophozite. Okay, so all 3 functions which are important to us, the infective stage, the pathogenic stage, as well as the diagnostic stage in trichomoniasis is the Trichomonas vaginalis trophozite. Okay, so there is no cyst stage. Now we'll look at the morphology. Now this is important. Now some of the introductory things that I said you can afford to forget, but this you have to know. Okay, right. So when you describe the parasite as far as your exam is concerned, you have to describe as if you will describe something to someone who is away from you, and if you're calling and describing something which is close to you, you will be showing, say, I have this remote control of the air conditioner, so I would say this is square in shape and it has buttons and it has 1 colored button, so on and so forth. So likewise, when you describe a parasite, you have to say start with the shape. So this you can see that it has a teardrop kind of shape. Okay, and then it has 1 nucleus. You can very well see that very quite prominent. There is 1 nucleus in the center, and also you can see that there is a structure in the middle which sort of bisect. It runs from the anterior end to the posterior end, dividing the cell of the organism. So this is a stiff structure which sort of gives strength to the parasite. Okay, so it's called exostyle. That also you can see under the microscope mostly. And then the undulating membrane is something like a fin of a fish, like it is in the lateral side of the organism, where it move with that movement, the parasite can move. So it's an undulating membrane which helps in movement of the parasite. And when I started, I said this is a flagellate, so which means it has to have flagella, and there are 4 of them in the anterior part of the parasite, and the 5th one is actually runs along the edge of the undulating membrane and projects from the posterior end. So you can see the posterior flagellum projecting at the posterior end of the parasite. Okay, so those are the features that you need to know. I have highlighted the features that you have to know, because at the exam I will show you a question, past OSCE question. We generally ask you to write one or two identification features. Okay. Do you have any questions so far before I move to the next question, next slide, next part of the lecture? If you have any questions, you can unmute yourself and ask. Any questions so far?
Madam, I have a small general question. Like, for example, is it necessary that we know the countries and the statistical prevalence of the disease?
No. When I mentioned about when I showed you the global prevalence slide, I said you don't have to, because I mean it's pointers of our checking you the prevalence and the certain epidemiological things. Unless it has something sort of, say now COVID-19, we have to know that it is all over the world because it's a pandemic, and then your traveling may, you may come across it during your traveling, and there are certain implications affiliated to that. But this is not something like that. You don't get it, like you get COVID. So this is, you don't have to know the prevalence or the epidemiology in most of the things. If it is important, we will mostly, parasitic diseases or any other microbial diseases or any other infectious diseases, we will tell you that, okay, it's important for you to know that which part of the world is suffering from this. But generally this one, definitely not. You don't have to know the statistics, because those statistics change. Even the diseases, say some of the diseases, now say in future I'll be talking to you about filariasis, that then I will tell you there is some relevance of the prevalence to the disease. In such diseases, we'll be telling you that, okay, this is important. Otherwise, generally no, because you can always turn a book and find out the prevalence, and it changes with time. Okay?
Okay, madam. Thank you, madam.
Right. So moving on, Trichomoniasis trophozite again. Let me play this video first. Okay, now you can see that, you can see that these are the parasites, the video. Hope you can see the video. Can you see the video? Puguduni?
Yes, madam, we can.
Okay, right, great. So you can see that they have a peculiar mode of movement. There is a peculiar mode of way of movement. Basically, there is no direction. It's rapid, and it has a kind of jerky movement. Okay, so that's the way you see in the real life under the microscope. And while they are moving, they are actively phagocytic, means they are eating up the bacteria in the vicinity, now in the vagina also, or in any other location. They'll have bacteria in the area, and they are just eating up and moving. That's why they are shaking. And okay, if I show you again, you can see that they are eating up the kind of bacteria around them. And their reproduction is by binary fission. That's by just dividing the cell into 2. And optimal growth, of course, moderately anaerobic, in the sense that you can see that I said this is in the genitourinary tract. So those areas generally have moderate anaerobic environments. So that's a kind of, I would say, their evolutionary fact. Okay, right. So moving on to the next slide. This is the habitat in both males and the females. It's in the genitourinary tract. GUT I have given here is not standing for gut. It's for genitourinary tract. Okay, right. So epidemiology, if the previous question was asked about this, of course, this is important because you have to know what kind of patients will have this disease, what kind of activities will put them into risk. So this, the data or the information given in this slide is important. Now, generally, this is trichomonasis is considered as a disease in the reproductive age because obviously this is sexually transmitted infection. So those who are sexually active only will get it. In the most of the instances, I'll tell you what the uncommon instances later. So those with higher, the chances of getting trichomonasis is more in those. The trend is rising with the age, and the trend is rising with the number of sexual partners as well. That is obviously because with age, your number of partners may increase, as well as your sexual activity may increase with age, at least during the reproductive part of the age. Okay, so those are the risk factors or the possible likelihood to get trichomonasis. So moving on to the transmission, I said it's a sexually transmitted infection. Why I say mainly is there are rare instances where the disease has been detected in babies who are born vaginally. So those babies can get it in rare instances if the mother is having an acute infection, but it doesn't matter much to the baby because it just gets sort of recovered on its own without treatment. They don't need any treatment. And this incubation period means when you get a patient, if you ask the history, well, the patient may tell that they had an exposure to an unknown partner, sexual partner, within a matter of 3 days or so, or it could be a month ago exposure. Okay, so the incubation period may vary from 3 days to 28 days. Okay, right. So pathogenicity, we are moving on to the pathogenicity now. If you have any questions up to now, you can ask me now also. Moving on to the pathogenicity now, this parasite does not invade. Now you learned about amoebiasis by now, I guess. So amoeba is a parasite which can invade into the intestinal tract, large intestinal tract. But this one, wherever it is in the genitourinary tract, it does not invade. It's just non-invasive. It just adhere to the surface and stay. So say if the patient is a female patient and the parasite is adhered to the vaginal mucosa, the vaginal mucosa will have a reddish, tender appearance. Now you have learned about features of inflammation as hopefully the first lecture, at least in our time, the first lecture, pathology lecture, was on inflammation, and they teach us the signs and symptoms of inflammation. So you would have, by now, if you had those lectures, you would know inflammation will make, if it is in the vagina, it will make it reddish and tender. And if it invades, if it spreads to the cervical, the cervix area, cervix will also be inflamed and it will have punctate hemorrhages, which gives the strawberry cervix appearance. Now here you can see that it has a bit of a strawberry type of look of the cervix. I hope you know what the cervix is because you have done your anatomy, even though you may not have done gynecoms by now, but you know what cervix is. Okay, so in severe infection, of course, ulceration can occur. We can skip that. So moving on to the clinical features, mostly whether it is male or female, most of them are asymptomatic. They will not have any symptoms as such. Females, they can have a discharge. That's the case history that I presented you at the beginning. That patient also had a vaginal discharge. Now this vaginal discharge could be clear, white, it can be yellowish. In certain instances, it can even be greenish in color. Okay, usually it forms a pool in the posterior fornix of the vagina if it is vaginal discharge. And when I talked to you, at the beginning, I told you that sometimes the presentation is common to others, which means there are other diseases, other sexually transmitted infections, which can present with a vaginal discharge. For example, one is candidiasis. It's a fungus. Another one is bacterial vaginosis. Both those diseases you will learn from microbiology. But if I just let you few points where you can compare and contrast. Now the Trichomonas discharge is a clear in the sense colorless, or it could be purulent later on with the invasion of pus cells. So it will be a bit of yellowish if so. Okay. Usually there's the amount of secretion is less in we'll say in trichomoniasis, but in candidiasis, if I start with the candidiasis has a very copious amount, a large amount of secretions coming. Candidiasis, well, I don't want to make you, hate cheese, but it has the cottage cheese appearance in candidiasis. It's a very white, thick, cheese-like appearance. And in all three diseases, the patient may get vulval itching. If I compare bacterial vaginosis, candidiasis, and trichomoniasis, in candidiasis again, the vulval itching is very intense. Patient feels like scratching to the, they cannot resist without scratching the vulval area because it's so stitching, itchy feeling is so intense that they feel like scratching even till it bleeds. Most of these patients will have a bit of bleeding also, simply because they have scratched so hard with the fingernails. So itching, vulval itching is more intense in candidiasis. Okay, and there is burning sensation in all of them, and all of them have this dysuria, that is burning sensation when they pass urine. Apart from that, in bacterial vaginosis, they'll have a fishy smell in the vaginal discharge. Okay, usually if the patient talks about a fishy, smelly, the vaginal discharge, it is bacterial vaginosis. Okay, right. So hope you know how to differentiate based on the history itself. Trichomoniasis, candidiasis, and bacterial vaginosis. So in trichomoniasis, if I stress the point, stress the important ones, in trichomoniasis, it's usually a clear or purulent discharge, whereas in candidiasis, it's a cottage cheese, like very white, thick discharge that they will have. And in bacterial vaginosis, they'll have a fishy odor in the discharge. Okay. Apart from that, if you consider the itching, it's very intense and more in candidiasis. Okay, right. Moving on to the features in the males, again, they are also majority of the asymptomatic. Because of that, mostly the female partner will get vaginal discharge and they will go to the doctor and get treatment, whereas the male who actually has the disease, who may have passed the disease to the sexual partner, the female one, would not even know that the patient has feces, because majority of the males are asymptomatic. In very less frequently, they will have urethral discharge, or they'll have burning sensation when they pass urine, or they'll have itching and irritation inside the penis because of the inflammation, or they have features of prostatitis and epididymitis. Okay, right. So generally, males, don't present with symptoms since they are mostly asymptomatic. But if there is a patient, a female patient, you always have to ask the number of sexual partners and trace them and treat them as well. Otherwise, male partner will pass the infection to the female. Whoever, male or female, the sexual partner will pass the infection, because most of them are asymptomatic, they won't know. So everybody should be treated. Okay. So moving on to the laboratory diagnosis. Now there are various laboratory techniques that are available, but of all those, only these first two which I have highlighted and not highlighted, given in the thick bold letters, are the ones which are being done in Sri Lanka. It's the direct microscopy of the saline wet mount, which is done as a bedside test. And then we can also do microscopy of stain smears. The other tests, actually, these antigen detection tests and the culture and the PCR and all that, are not done in Sri Lanka, I would say, except for research purposes. Okay. So microscopy of saline wet mount is the usual test that we do. The specimen should be examined immediately. That's why I said it's a bedside test. When you visit sexually transmitted infection clinics, you will observe that the doctors who take the specimens immediately, either it is being sent to the laboratory if the laboratory is close by, or they prepare the saline wet mount then and there and send to the laboratory. Because reason is this, we look at the specimen looking at the movement of the parasite. So before the parasite dies, before the movements are becoming sluggish, you have to send the sample to the laboratory. That's why specimens should be examined immediately. Okay, so in the identification under the microscope, you look at the shape and the presence of flagella and the way they move, if you remember the video that I showed you. So those are the features with which you recognize them as Trichomoniasis. Okay, Trichomonas vaginalis. So the specimen, we can take first voided urine, that's the urine that anyone passes the first as soon as they wake up from sleep. Both male and the female you can detect by using first voided urine, but in the female, high vaginal swab is preferred. Usually high vaginal swab is taken by inserting a speculum into the vagina. Usually they use Cusco's by valve speculum. So that's a preferable specimen. Whatever it is, it's a vaginal secretion is what is being taken. And in the males, of course, you can take urethral smears if they have a urethral discharge. Okay. So under the microscope, this is the way you see them. You see the shape and you see the exostyle, the nucleus, the undulating membrane and the flagella. So with those, you recognize them as Trichomonas vaginalis. So what happens is, even in the first case report that I showed you, they said they did papinicular stain. That means actually the pap smear is not done for trichomoniasis, but usually in the females, especially essentially after the age of 40, in other countries, they do a pap smear. That you will learn for pathology. So the pap smear is done to screen for cervical cancer screening kind of method. But when they do it, if there are trichomonas present, they report it. Okay. So even though pap smear is not done for this purpose, they report it in the pap smear. So that is again microscopy of stain smear, whatever you do. This is of course a Jim sustain slide. Okay, right. And I mentioned that you can do culture, but it's not so useful, or not, that's the wrong statement, I would say. It's not frequently done because even though Trichomonas culture is very easy to use, it is not being done mostly. So we have done it for research purposes, but for routine diagnosis, they don't do. It's very sensitive than wet mount. Usually these cultures are liquid media. That most of the culture media that you have seen are solid agar plate type of culture that you have seen in the microbiology department, but this one is a liquid medium, and there are various commercially available formats where they have you can just insert the swab into the envelope kind of pouch, and then you can keep it on the microscope directly to have a look at it. Okay, right. Now this slide is just for your reference. I'm going to just skip. This is just to know which one is more sensitive, which one has more specificity, and the kind of advantages and disadvantages. That is just for your reference. Okay. And this is the antigen detection technique. Again, I'm not going to go into details. These are, dipstick kind of test where there is a control line and a test line. So they will give a color reaction. Immuno means there's antigen antibody reaction. That means antigens are detected using the antibodies which are fixed onto this strip. And chromato means there is a color change. Graphic means it's graphically shown in the strip. Okay, so this is an antigen detection test, which is again I have done it, but not in the routine diagnostic laboratories. Okay, right. So moving on, again in other countries for sexually transmitted infections, they do NAT test for many sexually transmitted infections, even for trichomoniasis, but definitely not in Sri Lanka. We cannot afford to do PCR for all these, right? So again, like the previous slide, I have given some reference from literature, just to know which is more sensitive, which one is more specific, and so on and so forth, which you can just have a look. Right. So let's look at the treatment. Are there any questions up to now before we are reaching the latter part of the lecture? So if you have any questions, you can ask. You can unmute yourself and ask me questions.
Madam, what are the disadvantages of immunochromatography assay again?
In the previous slide, if you can see, this is ICT, means the antigen or the immunochromatographic test. Limitations, now here they have given one, but other limitations are now antigens can be there even if you say the patient has been treated and the patient has no live parasites, then they can have various antigen particles remaining. So those patients will also be, they are kind of, can't say they are false positive, but they'll be positive for a little longer than, you would like to know it, because by the time your ICT test positive, the patient is actually already recovered, but since they have antigen particles, they can be positive. That's one. And the other thing is based on the commercial now, of course, for Trichomonas, the antigen production kit comes only from one company. So they, of course, say their specificity is very high, and their sensitivity is also, they have given a high amount range. But say other diseases, if you take the sensitivity and specificity depends on the test kit, because the way they produce the test kit, say for you to detect antigens in a test, you have to have the antibody fixed onto the test strip, okay, like you do ELISAs. So based on the purification of the antibody that you have used, or based on the specificity of the antibody that you have used to create the test kit, your result may change. Those are the limitations. Okay.
Okay, madam. Thank you.
But then in Sri Lanka, except for at Jawadanapura, I don't think any others have this antigen test kit. Okay, right. So moving on to the treatment. Treatment is with metronidazole. It's a very cheap, very commonly available drug, and well, it has side effects in the sense, it's not a very palatable drug. It's a bit smelly, and people get nausea and vomiting when they take metronidazole. So those are disadvantages, but it's a cheap drug, so generally we ask them to take after meals so that nausea feeling is less, and they can try to get it on full stomach, so to reduce the side effects. Alternatively, we can give trindazole, again the same group of drug, but trindazole, of course, it's more expensive than metronidazole. Now I have given you the dosages which we prescribe, but actually we never ask you the dosages except for medical emergencies. You don't have to know these, because when you start practicing, you can initially look at the book and prescribe, and later on you will remember automatically what the dosage and the duration. Okay, so you don't have to know, just know what the name of the drug, that's enough. Okay, right. So apart from giving medicines, there are other measures in the management. One thing is, these are actually all these three things that I have put it here. These are all common things in sexually transmitted infections. if there's a patient with sexually transmitted disease, you look for other STIs, whether there are possibility, since there is a higher chance of that patient having more than one STI, that patient will be investigated for all the other STIs as well. That's a usual practice. And again, this is a usual practice as far as, till the end of the course of the treatment, patient is asked to abstain from having sex, because otherwise from the partner, they will get infected again before even completion of the treatment. Okay. And also, even though I haven't mentioned here, both the patient and the partner should be treated simultaneously when there is infection in one person. Okay. And then usually in all the STIs, they do a follow-up test of cure test. In Trichomoniasis, it's the microscopy of the saline wet mount that we have to do. The problem is that mostly the patients may not come for this, but if there is a possibility, you should do it. Okay. So these are common for every sexually transmitted infections. And there are other preventive measures like, as I said, you have to treat the patient as well as all the sexual partners, whoever with whom she or he is having sex with, male and female both. And health education is important. When I asked at the exam, what are the right one method of prevention of the disease, just don't write health education. It doesn't mean anything. You have to say what kind of things you do in health education. You have to say that you advise the patient to improve personal hygiene, because I said in the previous one of the slides in the epidemiology slide that there is a chance that those who have poor personal hygiene can tend to have more occurrence of the disease. And then in the health education, you have to write that you advise them to have safe sexual partners, or avoid to have multiple sexual partners. They can you can encourage them to use barrier methods of contraceptives like condoms. So those are the things that you have to tell in the health education process. Okay. So whatever you do, usually in this STI, the issue is they get reinfected because either they have not told the partner, or the partner has not got the treatment. So reinfection is quite common. So you will see the same person coming back to you after about 3 months or so. Okay, right. So in summary, this is a flagellate parasite, and it's a sexually transmitted parasite. It is the habitat is the genitourinary tract of both males and the females. Even though Trichomonas vaginalis, it doesn't mean that it's only the females. So both in both parties, male and female, mostly the disease is there's asymptomatic. People are asymptomatic. And in the female, it's a clear white yellowish vaginal discharge that they will have. They'll have itching, but not very intense itching like in candidiasis. And laboratory diagnosis is by microscopy of saline wet mount mostly, or microscopy of stain smear. And the treatment is with metronidazole. And there are various modes of prevention and control of the disease, that is treating the patient, treating all the sexual partners, asking them to abstain from sex until the treatment is completed for both the patient and the partners, and use of condoms or other barrier methods of contraceptives, and giving them health education as to what the disease, how do they get the disease, the mode of transmission, the clinical features, how can they prevent, what they should do if they have disease, and so on and so forth. Okay, so I have just put a question for you to try with those who have been listening. It causes bacterial vaginosis. Is this true or false? Someone?
False, ma'am.
False. Very good. It has 4 pairs of flagella. Is it true or false? Anyone?
False.
False, yes. It has 5 pairs of 5 flagella. Give me a second. Right, sorry. Infective stage to humans is the cyst. True or false?
False, ma'am. There is no cyst stage.
Very good. The only site of infection is the female genital tract. True or false? Only site of infection is the female genital tract. True or false?
False.
False, yes. It affects both gender and, well, it's gender tract, true enough, but both gender. And undulating membrane as it's in movement. True or false?
That is true, ma'am. It's like the fins.
Yes, true. Yes. Okay. D is not a good stem actually. It's a bit gray and confusing, so that's not a good question. The response D is not a good question. Right. So this is just, I quoted these two, of course, from a past paper. We have asked them, students to draw and label the morphological features that assist in identification of Trichomonas vaginalis under the microscope. And we have also asked you all to describe briefly. Now, when we say briefly, you don't have to go into the town. You can use diagrams, you can use flowcharts, and you can, write in, phrases without writing sentences. Even whatever you do in parasitology, when you're answering essay questions, if you remember, even if you don't write, even if you have written, drawn the picture and labeled the diagram, we generally tend to, award marks. Say if you didn't have enough time, if you have drawn the correct picture, we tend to give you marks. Okay, and this is just an example of a OSPI question. Well, these questions, of course, we don't ask so many questions. I just modified 2 questions and combined 2 and prepared this one just to show you what type of questions that we ask. But generally we don't ask 5 questions in within 2 minutes. You can, of course, you can answer this because it's a very straightforward question. But generally we ask about 3, maximum 4. Okay. So the answer to the case history that I gave is given here, which you can refer up later on. Since the time has elapsed, I'm going to stop. But please do ask questions. I mean, whenever you see me anywhere, you can ask me questions. I'm